Good morning, everyone, and thank you for joining us for the webinar Spotlight on Avian Metapneumovirus. We will start the webinar with a general introduction on Avian Metapneumovirus, the virus itself, distribution, pathogenesis, symptoms, control strategy, and diagnostic approach. After that, we will take you a little bit more into depth into the BioChek ART ELISA, Avian Metapneumovirus ELISA characteristics, and to end the presentation, we will go through some field data. Looking to avian metapneumovirus, it is a pathogen that causes an acute, highly contagious infection of the upper respiratory tract, and sometimes in laying birds it can be combined with reproductive disorders. It primarily affects turkeys, chickens, and ducks, but many other avian species are susceptible and may contribute to the spread. Avian metapneumovirus has been reported in pheasants, guinea fowl, and wild birds, but for this presentation we will focus on chickens and turkeys. All ages of birds are susceptible to avian metapneumovirus, but young birds seem to be slightly more susceptible. And avian metapneumovirus infections can cause significant production losses worldwide. The disease caused by avian metapneumovirus is often referred to as avian rhinotracheitis, in the past also avian pneumovirus infections. In turkeys, the name turkey rhinotracheitis is often used, and also in chickens for swollen head syndrome, avian metapneumovirus is considered to be the triggering pathogen in this syndrome. Avian metapneumovirus is an enveloped, non-segmented, single-stranded RNA virus which contains 8 genes. It belongs to the order of the Mononegavirales, the family Pneumoviridae. In that family, you have a genus Metapneumovirus and a species Avian Metapneumovirus. On the right side, on the bottom of the slide, you can see the order of the Mononegavirales. In the past, the pneumoviruses were classed as a subfamily under the Paramyxoviridae, but nowadays, based on structural and genomic differences, they are classed as a separate family within the order of the Mononegavirales. Looking to the subtypes, 4 distinct subtypes have been identified based on antigenic and genetic differences through neutralization tests with monoclonal antibodies and sequence analysis. So we have subtype A, B, C, and D, and there are also 2 new unclassified subtypes described, which were isolated from a gull and a parakeet. Clinical cross-protection between subtypes A and B has been reported, and also protection has been reported against subtype C when birds were previously immunized with A or B. The reverse was not observed. Looking to the distribution, and let's start at a very early beginning, avian metapneumovirus was for the first time identified in the late 70s in South Africa. At that time, a severe condition of rhinotracheitis was observed in multiple turkey flocks in South Africa, and it hit the local poultry industry really hard. Other known respiratory pathogens were ruled out through analysis, and an unknown agent was found that was later identified as avian metapneumovirus. From there, it quickly spread to Europe. Also, a second subtype popped up, subtype B, and it further spread through Europe, Asia, Latin America, and other countries. In the fall of 2023, avian metapneumovirus subtype A and B were also identified in North America and later on also in Canada. So today, subtypes A and B do have a global distribution. Next to subtype A and B, we also have subtype C. And in subtype C, two lineages are described. You have the North American lineage, which has been reported in the 90s in commercial turkeys in North America. And then we also have the Eurasian lineage, which is mainly reported in ducks and wild birds. There is one report on the Eurasian subtype C in chickens from China. And then the last well-known subtype is aMPV-D. This has only been detected once, retrospectively, in turkey samples from France out of 1985. Looking to the transmission, the main route is horizontal transmission through direct contact, bird-to-bird contact, or inhalation of respiratory secretions. Indirect contact through contaminated materials may also play a role in the transmission. Looking to birds appear to shed avian metapneumovirus only for a few days after infection, and from there it spreads rapidly through the flock and between farms. The short shedding period also suggests that there are no carrier animals for aMPV. On the vertical transmission side, today there is no clear evidence for vertical transmission, but it has been suggested in a couple of publications as avian metapneumovirus can infect reproductive tract, that vertical transmission may be short-lived and may play a very minor role in transmission. Looking to wild birds, as previously explained, wild birds are a reservoir for avian metapneumovirus and may play a role in the spread of the disease. Looking to the pathogenesis, the main replication site is the upper respiratory tract, and avian metapneumovirus seems to have a particular tropism for ciliated epithelial cells where it will replicate and cause ciliostasis and in the end even the loss of cilia. And in this way, and the virus also opens the door, or through infection, it opens the door through the loss of the cilia for secondary infections. It can also infect the reproductive tract, and it has been described that avian metapneumovirus might be distributed to other tissues through a short transient viremia. There are also publications which mention that macrophages can carry the virus, and immunosuppression was also reported in avian metapneumovirus infected birds. So in this way, together with the loss of cilia, it really opens the door even further for secondary infections. Looking to clinical signs, the clinical signs are non-specific respiratory symptoms, and the symptoms can vary from very mild to very severe, certainly in the presence of secondary infections and environmental distress. Morbidity rate can vary between 40 and 100% and can be even lower in chickens. Mortality rates between 0.4 and 50% have been reported. The onset of clinical signs is very rapid. Looking to clinical signs, ocular and nasal discharge varying from more serious to more mucopurulent have been seen. Rales, sneezing and coughing can be seen. Conjunctivitis, periorbital edema, and infraorbital sinusitis can also be seen. And sometimes you also will see neurological signs, opisthotonis, torticollis. In general, clinical signs tend to disappear within 7 to 10 days in the absence of complications. And what is important in laying birds, also temporary drop in egg production of 10 to 40% can be seen, as well as altered more worse egg quality. Looking to immunity, humoral and cell-mediated immunity do both play a role in the defense and protection against avian metapneumovirus. On the humoral side, it has been reported that neutralizing antibodies tend to increase and decline fairly fast, both locally and systemic, so they seem to have a limited duration. In contrast, ELISA titers seem to be more stable over time, and seroconversion seems to coincide with viral clearance. On the cell-mediated immunity side, also cell-mediated immunity seems to play an important role in the protection. Several studies reported an increase in the T-cell numbers in different tissues after infection with Avian Metapneumovirus. And looking then more specifically to local mucosal immunity, the entry site for the virus is the respiratory tract, so that is also the site of protection. And there, the mucosa-associated lymphoid tissue as well as IgA play an important role in the protection of mucosal surfaces. Many studies report that those local mucosal immunity seems also to have a limited duration, and that may explain why the field sometimes repeated infections of reconvalescent flocks can be seen. On the passive immunity side, maternally derived antibodies do not protect against field challenge, and it has been reported that high levels of maternal antibodies may interfere with live vaccines. Looking to control strategy, there is no effective treatment, so to prevent infection and to minimize the impact, we rely on biosecurity and prophylactic vaccination, and good management practices can decrease the severity of the disease. Looking to biosecurity, wild birds act as a reservoir and are therefore a potential source for virus introduction, so it's very important that we prevent any contact between wild birds and our flocks. Looking to avian metapneumovirus, it's a quite sensitive virus, both to physical and chemical agents. It is inactivated by temperatures higher than 50 degrees Celsius. With colder temperatures, longer survival rates can be seen. It's an enveloped virus, so therefore avian metapneumovirus is also sensitive to most common disinfectants. Looking to vaccination, there are commercial vaccines available. In most regions, we do have live attenuated vaccines, which most commonly are applied through spray and drinking water. Those live vaccines stimulate local respiratory and systemic immunity, but they do have a short-lived protection, so local immunity declines fast, and repeated vaccination is therefore common practice. We also have inactivated vaccines available. Those vaccines are applied to give a boostering of the circulating antibodies, and this is mainly done to offer protection to the reproductive tract. Looking to the diagnostic approach, clinical signs, as mentioned before, are not specific and can be very, very mild. They resemble other respiratory diseases, and therefore, based on symptoms alone, it's very hard to make a definitive diagnosis. It actually requires laboratory testing to make a proper diagnosis, and several tests can be used. Looking to samples, we can take swabs for virus isolation or for reverse transcription qPCR. Sometimes we also see that tissue samples are used for histology. Histology is offered in a limited number of labs, but can sometimes help. And then on the other side, we have antibody detection methods. So we take serum samples, which can be analyzed through ELISA or virus neutralization tests. But looking to the most common used tests in the field, lab tests, I would say this is reverse transcriptation, qPCR, and ELISA. Looking on the virus detection side or antigen detection side, we have reverse transcription qPCR. Subtype-specific assays are available, and also sequencing options are available to determine the subtype. PCR is mainly used for diagnostic purposes. Upper respiratory tract swabs are used, choanal, tracheal swabs, and what is important to realize is that there is only a narrow viral detection window, and this is due to the loss of ciliated cells, which really complicate antigen detection. So it's really important that samples are taken in the acute phase at the onset of symptoms. On the antibody detection side, the most common used test is ELISA. Those tests do not offer subtype differentiation, in contrast with virus neutralization, where you do have subtype differentiation. They are used both for diagnostic purposes, but also for vaccination monitoring purposes. Serum is the matrix used in these tests, and what we are going to look for is the level of circulating antibodies. It is important to realize that the level of circulating antibodies, the ELISA titer, do not per se equal protection against avian metapneumovirus. Looking to the BioChek ART aMPV ELISA, let's go a little bit more into depth into the characteristics of this kit. It's an indirect ELISA, and we use a 1 to 500 sample dilution here, an incubation protocol of 60-30 minutes. The cutoff to determine positive samples are considered to be positive when they have an SP ratio equal or greater to 0.5 or a titer equal or greater than 1656. With this kit, both sera from chicken and turkeys can be analyzed, and the kit detects antibodies against avian metapneumovirus subtype A, B, and C. It has a high specificity and a good sensitivity. Looking a little bit more into depth into the specificity, here you see the results from a study in which we analyzed 428 samples from SPF chickens, and for this trial, for the sample set we obtained 100% specificity. If you look to the graph, you can see that some of the samples do have higher levels of background, coming even close to the cutoff of the test, so occasionally false positives can be seen. Diving a little bit further into the specificity, on this slide, you do see the test results from a monospecific panel existing of 36 antisera against different other poultry pathogens, which was run on the BioChek aMPV ART ELISA. These monospecific sera are really hyperimmune sera, so they do contain high levels of antibodies against other poultry pathogens. And as you can see on this graph, all sera tested against other major poultry pathogens clearly tested negative on the BioChek ART aMPV ELISA. And then I highlighted here on this slide as some data which was generated against other avian Paramyxoviridae, because we do get a lot of questions regarding cross-reactivity here. So we purchased antisera from 3 different sources for Newcastle disease virus, Paramyxovirus 2 and Paramyxovirus 3, and we tested these hyperimmune sera multiple times on multiple ELISA lots, and as you can see on these graphs, on all occasions the antisera from the different sources tested negative on this kit. Looking to the sensitivity, here you see a summary in table format from well-defined avian metapneumovirus positive samples that we analyzed, but just to show you that with this kit we are able to detect antibodies against avian metapneumovirus in sera from both chickens and turkeys, where antibodies were induced after vaccination and or infection, and against subtype A, B, and C. So you see in the table some chicken samples, also looking to sample 9 and 10, samples derived from turkeys. The 3 subtypes A, B, C were included, and some of the samples contained antibodies induced by infection, others induced by vaccination. In this slide, I also present some sensitivity data which we collected in the field from non-vaccinated flocks, both chickens and turkeys, and these flocks did have a field challenge for subtype A, which was confirmed by PCR. And as you can see on the slide, with BioChek ART aMPV ELISA, all these flocks clearly tested positive on the BioChek ELISA, indicating that we do have a good detection for subtype A. On the next slide, you see some sensitivity data, which we also collected in the field. This time we took serum samples from 5 different turkey flocks, which had a field challenge for subtype B, and which were confirmed to have this challenge by subtype B by PCR. We collected serum samples X days, and depending on the flock, X days after the positive PCR samples. You see this on the right side in the graph. Here you see the interval between the positive PCR samples and the collection of the serum samples. And then you can see that for the first flock, 5 days after the infection was confirmed by PCR, we clearly have positive titers on the BioChek aMPV ELISA. So this clearly indicates the sensitivity of this ELISA. This is some data on a vaccination trial where chickens were vaccinated, one group with a live A vaccine represented by samples 1 to 11, and the other group with a live B vaccine represented, or samples represented, samples 12 to 23 represented the live B vaccine group. Samples were collected 14 days post-vaccination, and you can see for both the subtype A and B vaccinated group, antibodies can be detected 14 days post-vaccination. And then to end, I also want to share some data on the sensitivity for this kit coming from a vaccination challenge trial, which was published by Ball et al. In 2022. He did a study in commercial broilers, which he vaccinated with a live attenuated B vaccine at 1 day of age. The chicks were vaccinated by ocular and nasal inoculation, and as you can see, samples were taken 21 days post-vaccination, and you clearly see the increased antibody levels in the vaccinated group. Then those 2 groups, the unvaccinated and vaccinated groups, were further subdivided in 3 other groups. One group was challenged with subtype A, the other group was challenged with subtype B, and the other group served as a control group was not challenged at all. And here in the study, you also see as samples were then collected 10 days post-challenge for the unvaccinated group and the 2 subgroups which were challenged, one with subtype A and subtype B. You see a clear and significant increase in titers 10 days post-challenge, which is detected by the BioChek ART ELISA. Looking to the vaccinated group, also there you do see an increase in titers between the challenged groups versus the vaccinated control group. Thank you very much, and I will now hand the word to my colleague who will take you through some field data on the BioChek ART ELISA.
We have already heard a lot about avian metapneumoviruses and available diagnostic options. In next slides, I would like to present serology results when BioChek ART ELISA was used as a monitoring tool. As you already know, the kit detects subtypes A, B, and C of avian metapneumoviruses, and it's suitable for chicken and turkey sera. We have reference control to assure quality on assay performance. But what is also very important, the data collected from farms in different parts of the world allowed us to develop the baseline for interpretation of the results. To help in interpretation, we have also vaccination index, a well-defined parameter which can be easily calculated from mean titer and CV. The higher vaccination index, the better vaccination, but if it exceeds upper limits of baseline, it can indicate the infection. When is it worth to use ELISA for monitoring in vaccinated flocks? We can check maternal antibodies because, as we know, very high level might interfere with vaccines. We can check layer and broiler breeder flocks after live priming. It's recommended after 3-5 weeks after last vaccination. Inactivated vaccine can be checked after 5-8 weeks. At the end of production, we can find field pressure and decide on the changes to the vaccination program. Broiler flocks, it's recommended to check at the end of production. Turkeys, to monitor the vaccination at the end of production. In non-vaccinated flocks, we can use ELISA to monitor potential ART infections. In layer broiler breeders, it's recommended to test twice in rearing, in the middle and in the end of rearing, and in the production, at the beginning of lay, mid of lay, and end of production. In broilers and turkeys flocks, at the end of production. So, to sum up quickly, we can use ART ELISA to confirm the diagnosis, because as we remember, PCR sampling window is narrow. To monitor non-vaccinated flocks to find possible field challenge. To monitor vaccinated flocks to evaluate vaccination quality, to measure persistency of titers over time, and to improve and optimize efficiency of vaccinations programs. Let's talk more in depth about results we can expect. First, broiler breeders at the age of 18 weeks, vaccinated twice with live vaccine subtype B. There was no clinical signs, and the flock showed good performance. In our baseline, after such vaccination, we can expect mean titer between 4,500 up to 12,000. Tested at 3-5 weeks after vaccination. All samples should be positive and vaccination index should be in the range of 100 to 500. Those results are correct. We can see differences between them as they were collected on farms from different regions and different vaccination times. When are the results suspicious? After such vaccination program, we can suspect the challenge when the mean titer exceeds 12,000. So what we see in those cases? Here we have low CV, but we need to be careful when assessing this parameter because CV value depends on the time from infection to sampling. The last result is not good for a completely different reason. We have here quite low mean titer and 5 negatives from 30 tested samples. It is not what we expect after 2 vaccinations. Let's move on to broiler breeder results at the beginning of lay. Those flocks were vaccinated twice with live vaccines and received a booster of inactivated vaccine. There were no clinical signs and the flocks showed good performance. The baseline for such flocks is mean titer up to 25,000 tested 5-8 weeks after last vaccination. 100% seropositivity, and a vaccination index in the range of between 150 and 1000. As you can see, those results are in expected range. And let's look at the suspicious results after such vaccination program. We see mean titer higher than 25,000 and low CV, but as a confirmation, we have also vaccination index, which greatly exceeds 1000. The third result is an example of result which should make us review vaccination procedures. We still have 2 negative samples, although the flock was vaccinated twice live and once inactivated vaccine. Here we have results of infected, non-vaccinated broiler breeder flocks. Those are field data which confirm that BioChek ART ELISA is a suitable tool to confirm infection with both subtype A and B. Let's turn on to broiler flocks. Here we have examples of results from day-old chicks originating from vaccinated breeders. We need to remember that antibodies level in day-old chicks depends on vaccination program and health status of breeders, but also on incubation quality. We can expect mean titer even up to 12,000, but results above 8,000 are considered as high level, which means that they may interfere with early vaccination. So if you see a problem on the farm or you're not satisfied with your post-vaccination results, you may check maternal antibodies of day-old chicks and find out if their level is not high enough to affect vaccination. Here we have results of broilers vaccinated with subtype B vaccine at day 10, tested at slaughter age. After vaccination with subtype B vaccine, we can expect mean titer between 1,000 and 4,000, which is what we have on those results. It's worth to notice that they are partially negative. It's correct normal picture, and you may sometimes see even more negatives on your results at that age. So what will we see if the flock is infected? Those are results of broilers vaccinated and challenged tested at slaughter age. The mean titer definitely exceeds expected range. Please note that CV may not be low, because again, it depends on the time between infection and sampling. And results of infected, not vaccinated broilers tested at slaughter age. It's clearly visible here how the results can differ depending on sampling time. Shortly after infection, lower mean titer and high CV. And with time, mean titer goes up and CV drops. In closing, let me remind you about the importance of having own baseline. You can use BioChek baselines as starting point, but please be aware that it is general baseline, which needs to be adjusted to your reality due to differences in vaccination program, vaccine application methods, field pressure, and sampling time. Regional differences are very important. At the end, you need to also acknowledge normal variation of the results. That's all from my side. Thank you very much.